Yeah, thank you so much. I'm going to try and share just a couple of slides. Let me know if they don't appear. I think you should be able to see them. Hi everyone, my name's Sam Rodger. I'm here today on behalf of the new NHS Race and Health Observatory. It's an honor, first of all, to be here, especially alongside the other speakers on this agenda. So thank you, especially to the Association of Black Psychiatrists for having us. I'm going to talk a little bit about what we do and why we exist. We're quite a new organization, so hopefully, it'll be new information to many of you on the call. But I'll also talk a little bit about where we're focusing our attentions in our first year on mental health. So we're a new organization. Put simply, we exist to fund research into ethnic health inequalities, and we were set up at the start of this year, 2021, in reflection of the fact that in many ways, ethnic health inequalities are already very well evidenced, as we've heard so far this evening. We already know that Black and Asian women are more likely to die in childbirth, for example. We know Black men are more likely to be sectioned than white under the Mental Health Act. And we've all seen the disparate impact of COVID-19 on Black and Asian communities, especially over the last 18 months. But the observatory was also set up in recognition of the fact that in some ways we still don't know enough. We can see the evidence of these inequalities everywhere, but we don't always have sufficient data or knowledge to know exactly where to target our efforts in improving it, to know what works and what doesn't work. And I think perhaps most importantly for us, we don't always know how best to spread and embed that information. And speaking especially in an NHS context, that's one of the major challenges in changing policies. So the observatory works in three core ways. The first is in producing evidence, and that's either by synthesizing and promoting existing evidence, or by commissioning brand new research into priority areas identified by our expert working groups. And I'll say more about that in a second. But we also prioritize our projects based on broad stakeholder and community engagement exercises. The second thing we do is try to inform policy by disseminating that information through high quality research outputs, webinars, and engaging with groups like yourselves. And we always try, it's really important for us to, whenever we put out research, to also attach it to targeted actionable recommendations. Because as I'm sure you're all familiar, there's a lot of research out there that doesn't necessarily come with a call to action, or there are lots of reports that make very vague recommendations towards the government without identifying individuals, whether that be organizations or teams, who can actually make a difference. And finally, because we're funded by the NHS, we're also directly involved in the implementation of those recommendations, meaning we work side by side with policymakers to make sure those insights are actually acted upon. But I think one of the legitimate challenges we get is about impact. And so, as we'll know, really moving the dial on any kind of ethnic health inequality may take many, many years before we start to see the impacts that we're really aiming for. But in the meantime, we try to track our progress in a number of ways. And by the way, we're open to being challenged on these. As I say, we're publicly funded, we belong to everyone, and we want to make a difference. So the first way we try to make an impact is by driving policy change. Where we identify policies that do exacerbate inequality, we work to have them changed. The second is about shaping research priorities. Although there is research out there, this is an area that's often underfunded. So we use the work we commission to identify gaps and then work with bodies like NHSRHO to try and shape broader priorities. The third is about influencing leadership. So that's talking to leaders at all levels throughout the NHS and beyond to drive practical changes on the ground. And related to that, we talk about creating practical tools. So producing resources, not just for those leaders to apply, but for everybody, making the evidence available in an easily digestible and shareable form to empower people to demand change locally as well. And finally, we talk about engaging the public using traditional and social media outlets to raise awareness and stimulate debates. And one of the ways in which we can kind of demonstrate how we're having an impact is through some work we've done around pulse oximetry recently. Some of you may have seen our report, which was a rapid evidence review looking at the variable results you can get through pulse oximetry and based on the color of a person's skin. And the evidence we saw showed that it could be variable. And so we worked with NHS England, NHS Improvement, and other regulatory bodies to get clinical advice changed around pulse oximetry. And as those of you in the UK may have seen, the Secretary of State for Health and Social Care recently announced a broader review of racial bias in medical devices. So that's one example of a way that we're having an impact. I run out of slides here, but I'll leave this one up just, it's got our contact information on, and people can kind of follow us and get involved. But to talk briefly about mental health, we work through a distributed model, meaning our team itself is really small, but we work through a dispersed network of experts. And so in mental health, we have a standing advisory group that will exist for at least the first 3 years of our work. And this group includes psychiatrists, other clinicians, academics, representatives with lived experience, voluntary and charitable sector representatives, as well as senior NHS managers. And we work with that group to identify our research priorities. And based on their advice and the engagement we've done, we're now at a point where we're commissioning our first major piece of work in the mental health area, which is a review into the Improving Access to Psychological Therapies program, better known as the IAPT program, and something that I'm sure most of you are familiar with. This comes off the back of a number of stimulus, but there's a recent piece of research, especially looking at South London, that found in that area in particular, almost all racial and minority ethnic groups were less likely to receive an assessment compared to the white British group. And of those who were assessed, all racial and ethnic minority groups were less likely to be treated. So we want to commission a piece of research into ethnic inequalities generally in the program on a national level. So part of that means looking at the data to find inequalities in terms of the number of people being referred, the method of referral, waiting times, types of therapy offered, and of course the treatment outcomes for people going through that pathway. But it's also about experiences. And that's why we're also going to include a qualitative element to our research to understand the actual experience of service users. And that's something we're committed to across all of our work. We're not just interested in understanding access and outcomes, as important as those things are, but we're also interested in the experiences people have when interacting with NHS and other institutions, because we're especially interested in general in how institutions can work to exacerbate or eliminate inequality. And that means not just talking about race, of course, but about racism as well. And I want to paraphrase Professor James Nasru from the University of Manchester. He's a member of our board and our academic steering group. But I want to talk about the way he describes the different forms of racism impacting on health in a way that's shaped this work in particular. He talks about how structural racism impacts health at the societal level. As we've already heard, it shapes where a person lives, what resources they have access to, the types of jobs they do, and it's reinforced by the civic structures that shape all of our lives. And at the other end of that spectrum is the interpersonal racism, the discrimination between people in the health service, often in the form of neglect or dismissiveness, which devalue individual lives, leads to trauma and biological weathering, which of course in turn impacts health outcomes. And so in healthcare and in mental health, then institutional racism is the nexus between the two of those things. The institutions in which people receive care are where the societal forces that shape their health outcomes are played out between individuals. And so for mental health, and in the IAPT program especially, the racism is structural in the terms of the variable funding available, inadequate research, and the fact that some materials aren't translated into certain languages. And it's interpersonal in the sense of the stigma that shapes individual experiences, and about which Dr. Pedersen has just spoken. And that's why we're focusing this first piece of mental health research on that nexus, to understand how that program can better work for Black and other ethnic minority communities. But I want to end, and now we don't have much time, so I'll keep it relatively short. I want to end just by saying that this isn't our only piece of work, and one of the reasons it's a privilege to speak here is because we're really keen to engage. You know, we always want to have our door open and to hear from other people from all professions about what our priorities should be, which is why I've left this slide on the screen. to ask everyone to get in touch with us, follow us, and tell us what you think, and to challenge us however you see fit. I will end there. Thank you.